In addition to COPD, other obstructive disorders include bronchiectasis, cystic fibrosis, and asthma. In this next lesson, we will explore the etiology, clinical presentation, diagnostic testing, and treatments for each. Our first disease, bronchiectasis, has both obstructive and restrictive manifestations. It is characterized as dilation of the bronchi with irreversible chronic inflammation and recurrent infections. It also causes remodeling of the airway due to thickening, herniation, or dilation from repeated infections. Further remodeling occurs due to bronchial wall injury and subsequent weakness, traction from adjacent lungs with fibrotic changes, and bronchial obstruction. Localized bronchiectasis can be caused by inhalation of a foreign body, such as peanut or chicken bone, or an airway tumor or lymphadenopathy. Diffuse bronchiectasis is widespread fibrotic, bronchial wall, or lumen obstructions, generally caused by sarcoidosis, tuberculosis, etc. The difference is important when looking at further workup and treatment plans, and will be discussed in a minute. Symptoms of bronchiectasis include productive cough, more common upon waking, with mucopurulent secretions, often with thick yellow-green plugs, hemoptysis, and recurrent lung infections. Bronchiectasis is diagnosed by high-resolution computed tomography, HRCT scans. Criterion for bronchiectasis is, quote, when internal luminal diameter of one or more bronchi exceeds the diameter of the adjacent pulmonary artery, end quote. This finding is called a signet ring sign, where the artery looks like a quote-unquote jewel attached to the dilated bronchus, the ring. Nodules may also be present. Bronchiectasis can then be classified as one of three types: 1. Cylindrical, 2. Varicose, or 3. Saccular. Cylindrical bronchiectasis is characterized by smooth, parallel bronchial walls that don't taper normally. Varicose or varicoid bronchiectasis shows distorted and bulging bronchi like a varicose vein, and saccular bronchiectasis is characterized by bronchial dilation that increases toward the lung periphery, where the bronchi looks like a balloon. The saccular form is the most severe. PFTs may be normal in mild and localized bronchiectasis, but in diffuse forms, PFTs will show a reduced FEV1 to FVC and FEF 25 to 75%, reflective of medium to small airway disease. Residual volume will also be increased. ABGs will reveal decreased PaO2, but CO2 retention is rare. Blood tests to look for decreased IgG levels is important as immunodeficiency may play a role. Sputum testing will often reveal primarily Haemophilus influenza or Pseudomonas. Evaluation for reflux is important since GERD contributes to the development of bronchiectasis. Physical findings include crackles over involved lobes and rhonchi where mucus is retained. Decreased or absent breath sounds may be present when mucus plugging occurs. Wheezing occurs in a smaller percentage of patients. Accessory muscle use may also be present as the disease progresses. As there is no cure, treatment goals are reducing exacerbations and improving quality of life. To this end, identifying the underlying cause is important, as steroid therapy may be used for allergic forms or IG replacement for immunodeficient forms. During exacerbations, aerosol treatments, antibiotics for presenting organisms, and good pulmonary hygiene are extremely important to prevent any further airway remodeling. Surgery may be needed if patients present with uncontrolled massive hemoptysis. At this time, there is no prevention, although genetic markers are being studied. Pulmonary rehab may help in preservation of lung function. Our next topic in obstructive diseases is cystic fibrosis. This is a genetic multisystem disorder that affects children and young adults. It occurs when parents are both carriers of a mutation of the cystic fibrosis transmembrane conductance regulator gene, or CFTR gene. CF affects every organ that contains epithelial cells, with primary involvement in the pulmonary and pancreatic systems. The pulmonary system is affected by chronic airway obstruction and inflammation, thick tenacious secretions, and recurrent bacterial infections. The intestines develop thick mucus that interfere with absorption of nutrients and result in malnourishment. In addition, the pancreas develops exocrine pancreatic insufficiency, which affects fat digestion and the growth and development of individuals with CF. It also results in abnormal salt and water transport. Patients exhibit persistent cough and recurrent lung infections, meconium ileus at birth, which is an intestinal obstruction caused by viscous meconium, failure to thrive, and steatorrhea. excessive fat in the stool. As the disease progresses, patients often develop tenacious purulent green sputum as a result of Pseudomonas infection, and paroxysms that cause gagging and vomiting. Nasal polyps and sinusitis are also common. Pancreatic insufficiency occurs in 90% of patients, and fertility is affected in most males. Diagnostic testing occurs during newborn screening with a blood test to look for elevated immunoreactive trypsin levels, and if positive, then a CFTR screen. Final diagnosis requires a positive sweat test, which will show sweat chloride levels greater than 60 milliequivalents per liter. Chest x-rays will show hyperinflation and progressive parabronchial thickening. In advanced diseases, cystic lesions, nodular densities, bronchiectasis, and atelectasis will be seen. High-resolution computed tomography may also be used. PFTs will reveal small airway disease with increased RV, FRC, and TLC with reduced flow rates, particularly the FEV1 to FVC. Restrictive components of the disease may also be evident as fibrosis develops after repeated infections. ABGs often show decreasing PaO2s throughout the patient's life. An elevation of PaCO2 and FEV1 less than 30% of predicted are consistent with end-stage disease. Guidelines for CF care include CF clinic visits at least 4 times per year, 2 PFTs a year, respiratory cultures at least once per year, and glucose monitoring in patients 14 years or older, liver enzyme monitoring, and influenza vaccines every year for patients 6 months or older. The goal of this protocol include controlling lung infection, promoting lung clearance, and improving nutritional status. Other interventions may include treating CF-related diabetes, osteopenia, or depression. To reduce pulmonary infections, patients are encouraged to use airway clearance devices such as the vest, acapella, and PEP devices, and nebulizers as much as 3 or 4 times per day, practice good hand hygiene, avoid secondhand smoke, and participate in a monitored exercise program to maintain muscle strength. Since sputum viscosity is a complicating factor, patients may be prescribed rhDNase or pomazine, a DNA-cleaving mucolytic. If Pseudomonas infection becomes evident, patients may be placed on inhaled tobramycin, TOBI, on a 280-day on-off cycle. To control pancreatic insufficiency, patients are prescribed pancreatic enzyme replacements, which should be taken with food containing protein, fat, or complex carbohydrates. Fat-soluble vitamin supplementation and increased caloric intake is essential to ensure optimal growth and weight. Prognosis continues to improve, with a median survival greater than 37 years old, although 90% of patients die due to pulmonary complications, generally hypercapnic and hypoxemic respiratory failure, secondary to progressive airway obstruction. Cor pulmonale is a late complication of severe airway obstruction. For selected individuals with CF and end-stage disease, lung transplantation may be an option. CF screening and genetic counseling remain important for families who have had a child or first cousin diagnosed with CF. Our last disease in the obstructive section is asthma. It comes from the Greek word for panting, as patients' hallmark presentation is shortness of breath. It is a chronic inflammatory process in which many cells and cellular elements play a role, such as mast cells, eosinophils, T lymphocytes, macrophages, neutrophils, and epithelial cells. Episodes of wheezing, dyspnea, chest tightness, and coughing, particularly at night or early morning, are the result of widespread but variable airflow obstruction that is often reversible either spontaneously or with treatment. The prevalence of asthma has increased worldwide, and the CDC estimates that 25.1 million people in the U.S. currently suffer with asthma. Although there is a genetic component, asthma may be triggered by environmental factors as well. Some of these include allergens such as dust mites, pets, and molds, and non-allergens such as cold, air, exercise, and stress. Other factors that are currently being studied are the hygiene hypothesis, which suggests that our overly hygienic environments may prevent the protective force of early childhood infections, and Western diet and obesity are also being studied as potential factors. Risk factors that are directly correlated are smoking either during pregnancy or in the home, high intake of salt, and pet ownership. Diagnostic tests include patient history and physical, which include specific questions regarding allergies and exposures, auscultation, which often reveals expiratory wheezing during an asthma attack, PFTs that will show reductions in maximal expiratory flow and decreased FEV1, improvements in FEV1 greater than 12%, and an increase of FEV1 greater than 200 milliliters after a bronchodilator is considered reversibility of airway obstruction and may be used for a differential diagnosis compared to other obstructive diseases. Bronchoprovocation tests, primarily with methacholine, often called a methacholine challenge, is a definitive diagnostic test. It requires that methacholine be delivered in increasing dosages over 10-minute intervals until the FEV1 falls by more than 20%. The degree of hyperresponsiveness correlates roughly with the severity of disease. Medical management includes 1. Use of objective measures of pulmonary function to assess severity and to monitor effectiveness of therapy. 2. Identification and elimination of factors that worsen symptoms, precipitate exacerbations, or promote ongoing airway inflammation. 3. Pharmacological therapy to reverse bronchoconstriction and to reverse or prevent airway inflammation. 4. Therapeutic partnerships between the patient and healthcare provider. As mentioned in medical pharmacology, pharmacological treatments are divided into two classes. 1. Short-term relievers, such as albuterol, and 2. Long-term controllers, such as anti-inflammatories and long-acting bronchodilators. Prognosis depends on control of symptoms, but approximately 50% of children with asthma continue to have symptoms into adulthood. Preventing asthma episodes is largely contingent on removing any contributing factors such as pet dander or other allergens, and strict adherence to medical and pharmacological management. Peak flow meters may be useful as a tool to monitor reductions in airflow before symptoms arise.